Yeah,
Okay.
fine.
I welcome Dr. Jayalakshmi to take over.
Good evening, everybody. Best wishes to the newly formed scientific committee. And it started rocking already, so it's going to be a real good time for all of us. Today we have a very, very important and very common topic, management of diabetes mellitus and renal failure, which is very, very important. And as you keep seeing newer drugs on the horizon, we are going to learn a lot of new things. And the other topic is about IgA nephropathy, which is recurrent post-transplant, which is going to be an interesting case discussion. So I welcome Dr. Adlyne, Reena, and Dr. Changanidi, and the moderators, Dr. Indhumathi, Dr. Ranjanee, and thank you, Deepthi, for starting the session. So shall we go on to the session straight away? Can I ask the first session to be started?
Yes, ma'am. Thank you, ma'am.
Yes.
I would like to invite the moderator of the first session, Dr. Indhumathi, ma'am, to introduce the topic and the speaker.
Can you please share the Dr. Adlyne's slide, CV slide? Yeah, meanwhile, Dr. Adlyne, who is a professor of endocrine at Sri Ramachandra Medical College, from where I have been her friend for quite a long time. And in fact, her father was my teacher, physician at Madras Medical College, and a great teacher, Dr. Asirvatham. The family, she may be third or fourth generation of great family, doctor's family at Madurai. And so a perfect meticulous treatment I could see in endocrinology treatment closely with Dr. Adlyne. And she had her DM endocrine from Amrita Institute of Medical Sciences and DNB from Southern Railway Hospital and her MBBS from PSG Coimbatore. She has more than 30 national and international publications, co-authored many chapters. And so it would be interesting to know as we move forward, what we are seeing is in the management of diabetes. Earlier only it was glycemic control. Now we are looking into the drugs which has cardiorenal protection, multi-system protection. That is why it becomes more and more important to all of us. So I think she will knowledge us more and more about these and update on this topic. I call upon Dr. Adlyne to go ahead with the talk. Yeah, over to you, Dr. Adlyne. A warm welcome and to you. Yeah.
Thank you, ma'am, for the very kind introduction. And I thank the Women in Endocrinology team for having me here today. It feels really good to be among women, where I see women supporting women, encouraging women, and uplifting women, which again is very important and very relevant in the times that we live. So thank you so much for that. And it's indeed my privilege to be a part of the first CME that your group is conducting. So what I'll be talking to you about is the management of type 2 diabetes. We're all, as physicians, basically, are very much aware about type 2 diabetes, and our understanding of type 2 diabetes have changed from time to time. And what I will be doing in the next 30 minutes or so would be to give you a recap of what specific things that we do when we manage diabetes in patients with renal failure. So I'll walk you through a quick background of why it's important to know and understand diabetes, especially in the context of renal failure. What's so unique about managing diabetes in patients with renal failure? The challenges as endocrinologists that we face when we manage these patients, clearing up the air with some myths which has been in the past, which has been completely mitigated now. We will look at the guideline recommendations, the newer molecules on the block, and I will wrap it up with a take-home message. So these kind of pathophysiology that contributes to CKD is quite familiar. I don't have to preach this to a priest, but what I'm trying to convey is that the type 2 diabetes itself is a multifactorial disease, and we know that there are several factors that contribute to the progression of type 2 diabetes as well as the progression of chronic kidney disease as well. So there are multiple ways in which the progression happens. We know that we have the hemodynamic factors, the metabolic factors, the oxidative stress, endothelial dysfunction, several molecular abnormalities that happen that kind of fuel this entire pathway. Now, the most important thing that we need to remember is at the end of the day, we have one strong driver of this entire cascade of events, which is chronic hyperglycemia. Though we have several factors that contribute, many of the factors we are not able to address as treating physicians. But this one abnormality that looks very clear and very strong, which drives this entire pathway, is uncontrolled hyperglycemia. And that is what we are going to target today with this talk. So before we get into what do we really do about while managing patients with type 2 diabetes in the context of renal failure, we should understand the normal glucose homeostasis. Now, it's very simple to understand the pathophysiology of diabetes because we have two critical components that contribute to type 2 diabetes, one being beta cell dysfunction and two being insulin resistance. So these two critical components have to be affected before somebody has hyperglycemia setting in. Now, the major organs that contribute and probably have a significant role to play is the liver, adipocytes, skeletal muscle on one hand, which contributes to the insulin resistance component. And on the other hand, you have the pancreas and the beta cell that kind of contributes to the secretory effect of the beta cells. Now, there needs to be a balance that needs to be struck to maintain the glucose homeostasis. Now, what is the kidney doing in this complex interplay of all these organs? Now, we understand the importance of kidney only when the kidney loses its function. In the fasting state, we see that most of the times it is these organs which contribute to insulin resistance, tries to push up the glucose and maintain the glucose. Whereas in the fed state, we understand that these are the organs that are going to keep the glucose down with the optimization of the hormone levels. Now, what happens in fed state with respect to the kidneys is the fact that kidney takes up about 20% of the glucose that is circulated in the circulation and tries to excrete it so that it also contributes to glucose control in the fed state. Whereas in the fasting state, especially in prolonged fasting, we understand and learn these days that kidneys also contribute significantly to the glucose pool by increasing the renal gluconeogenesis. That is not less than 20 to 25% of the total glucose output that comes into the circulation. So this kind of importance is given to this organ where it's able to uptake the glucose. Also, it's able to get rid of the glucose into the circulation and contributing to maintain the glucose homeostasis. Now, what happens in early stages of CKD is the fact that we all know that there is a decreased insulin clearance and an increasing insulin resistance with a decreased beta cell secretory defect. So this combination of decreased insulin clearance, increased insulin resistance, and decreased insulin secretion pushes the glucose up compared to the episodes of hypoglycemia. To counter that, there is no glucose mechanism that kind of pushes the glucose. Rather, there is a decreased gluconeogenesis and decreased osmotic diuresis that also happens on the other end. But this mechanism clearly supersedes this half and therefore results in hyperglycemia. Now, what happens when CKD progresses? We all know that the insulin clearance is going to be lesser and lesser as the CKD progresses. But most important thing that reverses is this insulin resistance. So the insulin resistance goes off. You find that the insulin resistance goes up significantly, and that kind of contributes in the presence of decreased clearance and increased insulin sensitivity to hypoglycemia. So we are dealing with a very dynamic situation when patients develop CKD, where from significant insulin resistance, they go towards insulin sensitivity and from hypers to hypos. So what are the mechanisms of hyperglycemia in CKD? It's what I had discussed is about the insulin resistance because of the poor peripheral uptake of glucose in the skeletal muscle, liver, adipocytes, and primarily due to uremia, reduced insulin clearance, persistent inflammatory state, which we know that happens and fuels all the procedures on the pathways. Most importantly, you have the over-secretion of counter-regulatory hormones that happens during CKD, And last but not the least is the impaired osmotic diuresis, and therefore doesn't allow the glucose to get out of the circulation. So all these contribute to hyperglycemia, which becomes a task to get down in patients with CKD. Now, hypoglycemia also occurs in CKD because of all these mechanisms. Again, prolonged both an exogenous and endogenous half-life of insulin, the reduced insulin resistance or an improved insulin sensitivity, decrease in gluconeogenesis, poor nutrition, and what we actually call as a burnout diabetes. When the eGFR goes very critically low, there is an entity called as burnout diabetes, where all the alpha cells and the rescue mechanisms get shut off, and that contributes to severe and recurrent hypoglycemia in patients with CKD. Now, having talked about the hyperglycemia and hypoglycemia, we need to understand that it is not just a stage-wise progression of all the events. Like say patients are having hyperglycemia today, in the next 3-4 months, they develop hypoglycemia. It's not so. So what we need to understand is the glucose levels oscillates between hypos and hypers. So today you might see a patient with hypos, and tomorrow you would see the same patient with hyper, ranging from say 30, 40 to even 300 to 400 the very next day, or even the very same day at a later time. So that makes this glucose being dynamically having an excursion, making it very, very tough for us to optimize and get the glycemic curve as much as flat as possible. So all these mechanisms contribute to the fluctuating glucose, or what we call as an oscillating glucose, that puts it as a huge challenge in front of us to get the glucose under control. Now, what happens in dialysis patients? Now, we know that we always hold the insulin or any OADs that the patient is on the day of dialysis. Now, what is the logic behind that? What this particular observation showed is the fact in the same individual on the days of dialysis, you will find that during dialysis, the glucose drops significantly down, though it is not contributing to much of hypoglycemia. You will see a significant trough of glycemic variability, right from 250 to 80 to as low as even 110 or 120, which is 100 to 120 milligrams of drop. And then you see post-dialysis, immediately the glucose goes up significantly. So dialysis days are high-risk days where you can encounter hypoglycemia even while being on dialysis. And post-dialysis is the glucose surge that happens. Now, this is because of the increased erythrocytic uptake of glucose that happens during dialysis. And it has also been shown that during dialysis, there is a significant variation in the insulin secretion by the beta cells because the glucose sensory or mechanisms don't work accurately. And the third reason that has been quoted is the use of glucose-free dialysate these days. I'm sure I'm not aware of that personally, but this is what the literature says. So all these things contribute to a significant amount of hypoglycemia risk, followed by hyperglycemia in a given individual on the days of dialysis. Now, having looked at all these mechanisms that contribute to the glycemic variability and all those glucose dyshomeostasis, what are the challenges as endocrinologists we face? Now, the first challenge that we face is we have an individual with 300s, 400s, and 500s of plasma glucose, yet no overt hyperosmolar symptoms. We wouldn't see a polyuria, we wouldn't see a polydipsia, or we wouldn't see a polyphagia as well. So that kind of sometimes deceives us from perceiving uncontrolled diabetes unless for a glucose value check. So no overt hyperosmolar symptoms can be misleading, and that should not keep us from probably monitoring the glucose and achieving the glucose target that you would want for that individual. The second important challenge that we face is glycemic variability. As I already discussed, you have peaks and troughs of the glucose values that hovers through the entire day. So we need to have a good glucose monitoring in order to achieve the target. The third important challenge that we face is the risk of hypos. It's not about the simple level 1 or level 2 hypos. These are the individuals who are at a risk of having level 3 hypos, where the risk of having neuroglycopenia is quite high. And many times we tend to lose these patients either due to a cardiac arrhythmia or due to a seizure and so on. So these are the patients in whom our glycemic targets would be very less stringent, and we would not really look at a tighter glucose control. The other important thing is recurrent hypoglycemia. So these patients may have hypoglycemia, who recover from hypoglycemia following a meal or a glucose intake, but they are potentially at risk of having recurrent hypoglycemias, which also need to be kept in mind. The next important challenge that we face is hypoglycemia and awareness. Now, this is as a part of autonomic failure, but still what we really need to understand is patients apparently looking normal, getting a glucose value checked as a part of routine monitoring, and we find that the glucose values are less than 54 sometimes. So these kind of level 3 hypoglycemia with the hypo and awareness is a huge threat, because these patients most often succumb to a cardiovascular event, especially an arrhythmic event. So that also has to be kept in mind. And last but not the least is the progressive renal failure, because whom we see as CKD2 today ends up with CKD3A, 3B, 4, and 5 in few months, even few weeks, and sometimes even few years. So over a period of time, we need to keep assessing the glucose values of that patient, because the behavior of the glucose values can change over a period of time. You might have a very tough time with an individual because of glucotoxicity requiring 100 to 200 units of insulin. And suddenly you will find that once we tide over the glucotoxicity with recurrent episodes of hypoglycemia, and you might have to even withdraw insulin in these patients. So these are the challenges that we face as endocrinologists while managing patients with type 2 diabetes in the context of chronic kidney disease. Now let's move on to some beliefs that has been put inside our brains ever since our training days, and how it has evolved over a period of time. Now, the HbA1c has always been considered to be very less reliable in patients with CKD. We used to be trained in our medicine days where we would rather never get a HbA1c done. Of course, it was quite difficult in government setups, but still, even if you want to do a HbA1c, we would be asked as to if that would really help, and would HbA1c monitoring improve the patient's glucose profile and even complications. But now we know that the accuracy and precision of HbA1c does not vary much until you have an eGFR of 30 ml per minute. Even a lot of studies have shown that until an eGFR of 15, the HbA1c can still be used as a good tool of the glucose monitoring and the glucose assessment, because that helps us to intensify the glucose control. So the level 1C recommendation is HbA1c can be used as a primary tool for monitoring glucose control in patients with diabetes and CKD. Now, the second fact that has always been emphasized is, are CGM systems accurate in monitoring the glucose in patients with CKD? Now, what we now know is the fact that CGM is definitely accurate and is quite superior to even HbA1c in patients with CKD, except for the fact that when patients are on dialysis, when there's a lot of hemodynamic changes that can happen, there may be some interference in this continuous glucose monitoring, and therefore the CGM is recommended to help intensification of glucose control, especially when you have very high glucose values, very low HbA1c. Whenever you have discordance between your glucose and your HbA1c, CGM comes really handy to know the exact glucose profile of the given individual. Now, remember that the CGM monitors the interstitial glucose, and therefore is definitely lower than the capillary blood glucose that we monitored with the glucometer. Now, having said that, in advanced stages of CKD, as we all know, that there is a significant shift from the intravascular to the extracellular compartment, and therefore CGMs can be misleading in advanced CKDs. But even in patients who are on dialysis, CGM has shown in smaller studies to be very accurate in looking at the glucose profile, especially when you have patients on multiple daily doses of insulin and you really aspire to have intense glucose control. Now, a quick word about CGM, because there are three types of CGM or continuous glucose monitoring. We have the retrospective ones, we have the real-time CGM, and we also have the intermittently scanned CGM. Now, the retrospective CGMs are small glucose sensors which are placed or attached in the skin, either in the abdomen or in the back of the arm, where they are on for about a week. and then the sensors are removed and the reports are downloaded to see the graphs of the last 7 weeks. So they are retrospective, just like the ECG that we see of what has actually happened in the last few days. Now, the real-time CGM is like an ECG monitor. So where you put the sensor and either connect it via Bluetooth to your mobile, or you have a reader with you. So that kind of gives you the continuous glucose monitoring. It's very advantageous because you have bleeps that go up when there's a declining trend, when there's a risk of hypo, risk of hyper. You can customize and individualize the targets, and therefore it's really handy, especially in patients who are on multiple daily doses of insulin. Then you also have the intermittently scanned CGM, which is called as the flash glucose monitoring. You have a patch over there and just take the reader across the sensor and scan the sensor, and then you get the value. And you might do how much ever you want, you can scan and get these values. So overall, CGM is reliable in patients with CKD and can help you in intensifying the glucose values without having a hypoglycemic episode. Now, the CGM records look like this. You have the median, what you see in the blue line. Then you have a standard deviation of 25th and 75th centile, and then you have a standard deviation of 5th and 95th centile. So what you actually need to understand is that 70% of the day, patients have to be within the range. What we talk about as range is between 70 to 180 milligram, which is called as time in range. So 70% of the day, patients should be falling within this range. Anything more than 180 is considered as time above range, and anything below 70 is taken as time below range. So you want to improve the time in range and reduce the time above range and time below range in our patients. So this CGM monitoring really helps us to achieve the target. Very helpful in type 1 and also in type 2, especially when cost is not a big issue. Now, the third thing that we need to understand is the fact that glycemic targets are thought to be relaxed in patients with CKD because they did not want these patients to have an event of hypoglycemia and probably end up in the ER. But now we know with a lot of newer drugs that we have in the clinical practice now, the SGLT2 inhibitors, GLP-1 receptor agonists, metformin, and a lot of newer analog insulins, especially the ultra rapid acting analog insulins, can help us to achieve the intense glucose control that we would want to without having to pay for a hypoglycemia. So therefore, we need to individualize the glycemic targets and choose the appropriate drug to achieve the control and not worry much about hypoglycemia. Now let's move on to the guideline recommendations as to what is the numbers are that we are looking at and how do we really try to achieve those numbers. Now this is the ADA-AACE recommendation of glycemic target for patients with CKD. Now you can see a wide range of allowance with HbA1c from 6.5% to 8%. And what we actually try to do is choose a glycemic target for that individual who is sitting across the table and then try to achieve that. Now, there are several parameters that you need to look at before you really decide on the target HbA1c. Now, if you have an individual who has a very less severe CKD, not much of macrovascular complications, no comorbidities, then you would even aspire a 6.5% HbA1c and be a bit more stringent compared to those patients who are at advanced stages of CKD, lots of macrovascular complications, and several comorbidities that can actually push them into a risk of hypoglycemia. Again, when you have a good life expectancy and when you have patients who are having awareness during the episodes of hypoglycemia and patients who can be helped to treat and recover from hypoglycemia, of course, you can still go ahead and achieve a 6.5% A1C. Whereas if you don't have all these features, then probably you can be happy with an A1C less than 8%. And of course, when you have better drugs, think about 6.5. When you are in a setup where you can't really have these drugs, or when patients can't afford to have these drugs, then fine, then you can actually have an A1C even up to 8%. So this gives a wide target of HbA1c where you can individualize the target for that individual and probably plan your therapy for that. Now, why is it important to talk about HbA1c? We know higher the HbA1c, the more is going to be the morbidity and mortality. Now, this is the no CKD trial, which primarily looked at the association of HbA1c and the morbidity and mortality. Now, what they primarily looked at, they had patients who had A1C less than 7%, what you see in the broken lines, and they also had patients who had A1C more than 8%, what you see in the slight gray line. And then you have patients who had A1C between 7 and 8%, what you see in the bold line in between. So what they actually showed was patients who had HbA1c more than 8% as well as less than 7% did have a higher risk. What I'm trying to say is the MACE events were higher in patients who had both HbA1c less than 7 as well as more than 8, and therefore an optimal glucose control of 7 to 8 becomes more doable and more practical to improve the outcome with regards to the cardiovascular and all-cause mortality. Now, let's move on to the treatment of diabetes per se. I'm trying to keep the CVD management and CKD management away from here because as an endocrinologist, I'm more focused about management of diabetes and not just the glucose control, but also by addressing all the comorbidities that can actually coexist in our patients with type 2 diabetes. Now, we know that metformin is still the first line of anti-diabetic drug that has been used in the management of type 2 diabetes. And as per the recommendation of American Diabetes Association, American Association of Clinical Endocrinologists, and even all the European guidelines. So overall, metformin still stays and will stay to be the first line anti-diabetic drug that we can use for our patients with type 2 diabetes. Now, then we have these two molecules, the SGLT2 inhibitors and the GLP-1 receptor agonists, both of which were primarily not meant to be an anti-diabetic drug. The SGLT2 inhibitors, though was considered to be an anti-diabetic drug, did show a dramatic improvement with regards to the cardiovascular mortality and morbidity reduction, regardless of the glucose lowering ability. And therefore, it went up to the cardiologist. And then with the good renal data, it moved over the portfolio from cardio to nephro. And now it is also rests with the hepatologist because of the potential benefits in the MASLT with SGLT2 inhibitors, especially dapagliflozin. So the SGLT2 inhibitors are, it's almost like one stone, two birds. You have SGLT2 inhibitor on board. You take care of diabetes, take care of CVD, CKD, MASLD, several birds. So I think SGLT2 inhibitors, as and when patients tolerate, will still remain to be the second line of drug that you would consider for patients with type 2 diabetes and CKD. Now, the third group of drug that will be considered is the GLP-1 receptor agonist. Especially more emphasis is being given for a long-acting GLP-1 receptor agonist, which we'll be discussing a little later with regards to the management of type 2 diabetes and CKD. Now, the short-acting GLP-1 receptor agonists are more often considered to be an anti-obesity drug, which primarily results in weight loss, whereas the longer-acting GLP-1s are more potent with regards to the glycemic control. So overall, these two classification of GLP-1 receptor agonists exist and can be used appropriately given the clinical scenario of the patient. Now, all these molecules are in addition to the lifestyle modification of weight loss, diet restriction, exercise, more importantly, addressing the other comorbidities and cardiovascular risk factors by lipid control, blood pressure control, smoking cessation, and so on. So how do we really choose the anti-diabetic drug when you are really having a patient with CKD? Now, there are several factors which we talk about with regards to what really is contributing to the diabetes for this patient. Is it the insulin resistance component, or is it the beta cell secretory defect, or do we have to start OAD? Do we have to start insulin? So depending on the clinical situation, the glucose profile, the phenotype of the patient, the target that you would want to achieve for the given individual, and the ability of the patient to monitor the glucose and up-titrate the doses. These are the several factors that you would have to consider before really choosing an anti-diabetic drug in our patients. So the first important thing that we need to keep in mind is what would be the choice of drug when you are really looking at glucose control or intensive glucose control, where you are attempting to retard the progression of CKD. Now, these are the group of patients who fall under this category where you are primarily looking at glucose lowering efficacy of the molecule. Then without doubt, you have insulin on board, then which is followed by GLP-1 receptor agonist. Now, the A1C reduction that you would expect with insulin and GLP-1 receptor agonist is about 2%, more than 2% with insulin, especially with multiple daily dose of insulin. And therefore, if you are having an A1C reduction, aspiring for A1C reduction more than 2%, you have to resort to insulin or GLP-1 receptor agonist, either of them or both of them, depending on the clinical scenario. Then beyond this, you may even consider the DPP-4 inhibitors, alpha glucosidase inhibitors for that matter, in these patients because they are weight neutral, they have a low risk of hypoglycemia, and they have an insulin sensitizing property. Therefore, they can actually bring down the total daily dose of insulin, which becomes very beneficial for these patients because the risk of hypoglycemia comes down significantly. Now, the second group of patients are the ones in whom you just have to control the glucose and avoid hypoglycemia. Now, these are the patients who would rather benefit from the insulin-independent molecules like GLP-1 receptor agonists, DPP-4 inhibitors, alpha glucosidase inhibitors. Thiazolidinediones, yes, to some extent in the early stages of CKD, of course, needs a lot of caution, especially when our patients can quickly go in for a volume overload. Then again, we have the newer insulins and shorter acting sulfonylureas that can also be used when you really want to avoid hyperglycemia. Avoid injections. We have lots and lots of oral medications, including the DPP-4s, alpha glucosidase, sulfonylurea. We also have the oral GLP-1 receptor agonists now, which can be used in patients, especially when they really want to avoid an injection. Weight loss, again, gone are the days where we talk about CKD with cachexia and skeletal muscle mass loss. We do have patients who are obese and obesity-related CKD and progression, and therefore GLP-1 receptor agonists come very handy without SGLT2 inhibitors, can be tried in patients in whom you want to have a weight loss as well as a good glucose control. Of course, low cost, we have a lot of drugs with the loss of patency with DPP-4 inhibitors and SGLT2 inhibitors. You can still consider DPP-4 and the SGLT2 inhibitors even when patients are unaffordable. And when you have a worsening of renal failure, eGFR less than 15, you still can use DPP-4 inhibitors like linagliptin without dosage reduction, insulin, thiazolidinediones. I'm not quite comfortable using that, but recommendations say that with caution, we can still use, and not much of SUs and AGIs because we have quite a lot of drugs that can help achieve glucose control without hypoglycemia. Now, moving into the cardiovascular risk category, if you have a patient who has a predominant heart failure and hemodynamic abnormality, we would rather choose SGLT2 inhibitors followed by GLP-1 receptor agonists. And when you have an individual with a high risk of ASCVD, GLP-1 receptor agonist comes forward and followed by the SGLT2 inhibitors. So overall, this wheel helps us to think and choose the drug that would be beneficial for the given individual with diabetes and CKD. Now, these are the list of drugs that we had already discussed about, and we will see that most of the drugs need dose reduction as there is a progression of CKD, which we are all aware of, and that has to be kept in mind. Now, these are the medications like pioglitazone, exenatide, and saxagliptin, which have to be used with significant caution because though there is a lot of data to say that dose reduction is sufficient, we don't have clear recommendations from either ADA or AACE to be used in CKD patients beyond stage 3. Now, this is to give you in a nutshell as to the duration of action of these molecules. Now, all these duration of action are being said only in those patients who have a normal renal function. So depending on the eGFR and depending on the glucose profile, you might have to adjust the dose of all drugs except for a couple of drugs, one being insulin and two being linagliptin. Almost all of the other drugs need a dose modification. Now, what are the drugs that can be used in patients with who are on dialysis? Again, linagliptin without dose modification. Ripaglenide, again, very short-acting glenide that can be used without the risk of hypoglycemia. And last but not the least is the insulin that can still be used at any stage across all eGFRs. Now, this is the ADA KDIGO recommendation 2022. I'm sure all of us would be familiar about this. The first and foremost foundation of any metabolic disease management is the lifestyle modification, which includes diet, physical activity, smoking cessation, and weight management. Looking at the pharmacological therapy, it's first it's SGLT2 inhibitors, followed by metformin. And if it's not sufficient enough to get the glucose in target, then you can consider GLP-1 receptor agonist, followed by all the other medications, including insulin. Now, this is the flowchart that has been put forward by the A.R.A. and KDIGO in 2022. Now, what are the things that we need to keep in mind when we have patients who are on these three drugs that has been recommended by A.R.A. and KDIGO? Now, patients on metformin, again, less than 45, it would be better to reduce the dose of metformin, and less than 30, it would be better to stop metformin. And always watch for lactic acidosis. Though we don't see much of lactic acidosis, unlike the days when fenformin was used, it is very, very rare to find patients with lactic acidosis due to metformin. However, whenever you have patients who have sepsis and ongoing infection, then probably the risk of acidosis is slightly more, and probably we might have to withhold metformin for a short while. Again, patients who are on metformin for a long term, especially more than 4 to 5 years of use, a concomitant vitamin B12 deficiency can coexist, and that has to be kept in mind and corrected when we are going to continue patients on metformin. SGLT2 inhibitors, we have now strong data to suggest that it can be continued even until dialysis or even in transplant patients. But initiation is the key, where you are, the KDIGO recommends initiation of SGLT2 inhibitors when the EGFR is more than 20, and probably continue if the patient is already on SGLT2 inhibitor and is actually doing well with a stable EGFR. Long-acting GLP-1 analogs, again, we have data only until EGFR of less than 15. And of course, it comes only after metformin and SGLT2 inhibitors. Generally, the preference of GLP-1 receptor agonists in patients with CKD is less preferred in our setup. One, because of the GI side effects that are more pronounced in patients who have significant uremia, patients who are already cachectic, patients who are already losing significant amount of weight, and more importantly, cost. So considering all these things, GLP-1 receptor agonist may not be the first and foremost drug that you would want to choose for CKD. But however, we have significant amount of renal benefits that happens with GLP-1 receptor agonist, especially with the flow trial, which I'll be discussing in the subsequent slides, that actually kind of brings the GLP-1 receptor agonist use quite in front, very next to SGLT2 inhibitors and metformin. Now, I'm not going to go into the details of all the cardiovascular and renal data that we have with all the gliflozins. Now, regardless of whether it is SCANA, DAPA, EMPA, except for the etugliflozin, we have very significant and strong data of all the gliflozins, especially DAPA, in all these patients who are having either CKD, heart failure, ASCVD, and whatnot. So all these benefits of these class of drugs helps us to not just treat diabetes, but treat the metabolic dysfunction and the abnormal metabolic milieu as a whole. That helps us to retard the progression of CKD, succumbing to a cardiovascular event, and also all-cause mortality. So that way, this class of drugs, I'm sure all of us are using, can really help these patients beyond glucose control and addressing the other extra glycemic benefits. Now, these are the newer molecules that we have on board for management of type 2 diabetes, especially in patients with CKD. Now, we have the semaglutide, the injectable one, which is still not available in our country. It's expected to be launched maybe early next year or so. But what we now have is the oral semaglutide. Now, the injectable semaglutide is the once-weekly injection, which is a GLP-1 analog, which comes in 1 milligram and 0.5 milligram dosages. This is the flow trial that was published recently in the NEJM, which showed that the risk of having a major adverse kidney events was significantly lesser in patients who were put on injectable semaglutide 1 milligram once a week. And these patients were already at high risk CKD, and they showed that there was a 24% risk reduction in patients who were on semaglutide in CKD. So therefore, the semaglutide is actually expanding the indication to be used in management of type 2 diabetes and CKD, not just about the diabetes management, but also about diabetes and CKD management with regards to all the long-acting GLP-1 analogs. So what we have now is the liraglutide, we have semaglutide, we have dulaglutide. All three of them have a very strong data with regards to the renal outcomes. the next expected to be launched, which really helps in management of diabetes and CKD, is the tirzepatide. Now, tirzepatide is also called as a twincretin because it is a combination of GLP-1 analog and GIP. Now, GLP and GIP go hand in hand. It was initially recognized that GLP-1 has a more potent effect on the glucose control, but now we realize that actually it's a GIP along with the GLP which kind of offers all the benefits with regards to the glucose control and the weight benefit. Now this has been launched. The world is expected to be launched in India early next year. And this has also shown that significant improvement in the renal functions in patients with diabetes and CKD. Now, all these benefits has been studied until an eGFR of 45, and therefore we still do not have data less than that. But of course, in the days to come, we will have more and more data to recommend the use of these newer molecules and GLP-based therapies in the management of diabetes and CKD. Now, this highlights all the possible benefits can get with the molecules that has been recommended to be used in patients with type 2 diabetes and CKD. So then comes the hero of the diabetes management, which is the insulin. Now, when in doubt, what drug to choose? Choose an insulin and you will never be wrong. Now, it's not about choosing insulin, but it's about choosing which insulin and when and how. Now, this becomes very difficult. Lot of clinical reports. So we have the basal insulin, which are quite long acting, which acts even until 24 to 48 hours. And their primary mechanism is by suppressing the hepatic glucose output and therefore mainly targets the fasting plasma glucose. And then we have the prandial insulins, which have a potent effect on the beta cells with regards to insulin secretion in response to the glucose surge. And therefore, they mainly target on the postprandial glucose, compensating for the beta cell secretory defect. Now, what we conventionally do is we do give basal insulins when you really have a patient with isolated fasting hyperglycemia. Whereas if you have a patient who has an isolated postprandial hyperglycemia with a good-looking fasting glucose, then you would just opt for a prandial insulin. Now, unfortunately, most of our patients do have a combined hyperglycemia where they have fasting and postprandial glucose excursions, and therefore you either have to give a basal bolus regime with 3 bolus insulins and 1 basal analog, or you can go off the premixed insulins or the co-formulation where you have a combination of both. Now, the choice of insulin depends on the glucose profile of the individual, the postprandial glucose surge. If you have a high fasting, then more basal. If you have a high postprandial, then it should be more prandial. If you have both, you can give a premixed or co-formulation twice a day to take care of both, or even resort to a basal bolus insulin. Now, there's no one rule to say which insulin that has to go for an individual. It comes with practice and the pattern in which the patients behave, the glucose, the eating profile, the calorie intake of the patient, and of course, the target that you would want to achieve. Now, how do we initiate insulin? We all your patients are going to be very, very insulin sensitive, and therefore the titration or the initiation of insulin dose is going to be the lowest for patients with CKD. And therefore, you start at a very low dose and up titrate based on the glucose monitoring, unlike patients who do not have CKD or who have a significant insulin resistance. Now, CKD patients fall under 2 categories where you have extreme insulin sensitivity and extreme insulin resistance. And many times they interchange. So when you have an individual who is requiring 100, 200 units of insulin, beware that the insulin sensitivity is going to improve suddenly, and you will see recurrent hypos requiring a good down titration of the insulin dose, and sometimes these patients go off insulin as well. So as I told you, as the CKD stage progresses, the total insulin dose comes down to as much as 60% from what you had actually started. And that makes the glucose monitoring to be very important, very essential in your high-risk individuals. Now, the target of glucose has been forward by the A.R.A. as fasting less than 130 and postprandial less than 180. However, an individual target has to be set without having hypoglycemia at the ease of the patient, especially when you definitely require monitoring of glucose with either a glucometer or with a CGM before you really put them on multiple daily doses of insulin. So I would like to summarize my talk by saying glycemic control still remains to be the most important factor that needs to be achieved and addressed, especially when you are really trying to delay and retard the progression of CKD. Ideal HbA1c target can be kept about 7%, but that needs to be individualized, and you need to assess the patient and fix the target that you would want to achieve. Several anti-diabetic drugs are available in the market. It's very difficult to put everything in one particular talk, but we are having a lot of molecules, but we need to into molecule, using the dose, and again with appropriate monitoring, we are able to achieve the glycemic control that we would want to in that given individual. Now, last but not the least is the optimization. Always choose the drug, choose the dose, decide the frequency, glucose monitoring, fix a target, and more importantly, beyond the glucose control, look at the extra glycemic benefits with regards to CV risk reduction, renal risk reduction, fatty liver reduction, and also most importantly, reduction of microvascular complications like retinopathy and neuropathy whenever we are actually looking at diabetes management. So thank you very much for listening, and I would be happy to clarify if you may have any doubts. Thank you very much.
Yeah, that was an excellent lecture, and all the practical problems were addressed by you. So elaborate, so simple, and of course, it was really, really very useful to all of us, Dr. Adlyne. It was excellent. And now Dr.
Thank you, ma'am.
Deepthi can read the questions from the chat box so that she can answer all those.
So I have one question in the chat box. They say, ma'am, is the risk of vitamin D deficiency with metformin higher in CKD patients, or is it the same for patients with normal EGFR?
You mean vitamin B12, I think.
B12.
So the vitamin B12 deficiency is the same in patients with CKD and without CKD. It comes with the prolonged use of metformin. So the A.R.A. recommends the monitoring of vitamin B12 every 4 years when the patients are on metformin, regardless of the dose. Patients may be just on 500 milligram or 2 grams. So regardless of the dose of metformin, vitamin B12 has to be monitored. Even if you're not able to monitor, supplementing B12 would really do. And most of times that's what we get to do, because checking B12 is quite expensive rather than actually prescribing them a vitamin B12.
Correct. The next question is, at what dose would you start the repaglinide?
Yeah, so repaglinide comes in a dose of 0.5 milligram and 1 milligram. It's not a very potent molecule like what you would expect with a sulfonylurea. It's in between, say, a metformin and a sulfonylurea, something very similar to your DPP4 inhibitor or SGLT2 inhibitor. It has a very modest A1C reduction of about 0.7 to 0.8%. So whenever you have patients who just have to be taken care of with the postprandial surge, say fasting is very good, postprandial is just about 200, where you are looking at a 20 milligram, 30 milligram reduction of postprandial, then the glenides come very handy to be used. And you can use it twice or thrice a day with each meal, very similar to the alpha glucosidase inhibitor like carbose and uglibose that we use, but of course needs a good amount of monitoring.
Okay. The next question would be, how frequently should we check CBG in a patient on dialysis? Blood flow?
Yeah, there is no particular recommendation as to the frequency of glucose monitoring, but I would say depending on the agent that the patient is on. So if you have a patient who is on a basal bolus insulin, yes, you need a frequent monitoring, at least twice or thrice a week. It's very essential to monitor. If you have a patient who's just on a basal insulin with an OAD, maybe once or maximum twice a week would suffice. If you have patients who are on OAD, say for example, you have a patient on linagliptin or you have a patient on SGLT2 inhibitor, then I think the frequency can be even more lesser. So depending on the risk of hypoglycemia and the agents that you have, I think the frequency has to be customized.
Okay. The next question would be, can we start acarbose in stage 3 or 4 for postprandial uncontrolled glucose control?
Yeah, acarbose can be used until a of 30 ml per minute. But the only problem is it can cause some amount of bloating and GI intolerance. So if you have patients who are tolerating, actually the thing is, if you start, the recommended dose is 50 to 100 milligrams of acarbose per meal. But what we actually use is only 25 milligrams. So we start with 25 milligram, up titrate slowly, depending on the GI effects. And then actually you can up titrate as and when tolerated. But most of our patients do very well on 25 milligram twice a day, thrice a day, even up to 50 milligram. I have not had patients who are on 100 milligram TDS, which is most often seen in the Western population. So yes, you can use acarbose at all stages of CKD, but start it at a smaller dose, up titrate slowly, and watch for GI effects.
Right. The last question is a single episode of complicated UTI contraindication for reintroduction of the SGLT2 inhibitors?
The answer is no. If you have the previous recommendation was whenever you have uncomplicated UTI, a first episode of UTI, when you have a trigger, then yes, you can reintroduce the SGLT2 inhibitors with a good amount of precaution. But complicated UTI, the initial understanding was not to reintroduce, especially when you have a strictured urethra or a BPH, where you are having an individual who's already having a high risk of UTI with recurrent UTI, especially pyelonephritis. But the newer guidelines, I am yet to restart in any patient with complicated UTI, but the recent Infectious Disease Association guidelines, the IDSA actually has put forward that the SGLT2 inhibitors, given the benefits, should be reintroduced even in complicated UTI. But there is no such recommendation from A.R.A. or AAC as of now. So as it stands, it would be better to avoid in patients who have complicated UTI.
Oh, I think we have one more last question.
Yeah, with this we will
We
close
will
the
proceed
question
to the
session
next
also.
one.
Yeah, yeah.
Yes,
Yeah,
ma'am.
please finish.
I think they're very interested in asking questions. The next question is, in a patient with good glycemic control with metformin and sulfonylureas, if we decide to start them on SGLT2 inhibitors for cardiovascular protection, how do we titrate the dose of sulfonylureas?
Actually, SGLT2 inhibitors are now indicated as an add-on drug regardless of the HbA1c. So you don't have to look at the HbA1c or the glucose control if you're going to add SGLT2 inhibitors for cardiovascular protection or renal protection. Now, having said that, the insulin sensitivity improves dramatically in certain patients and poses the risk of hypoglycemia. So therefore, you have to come down on the sulfonylurea, especially when you have patients who are on glimepiride, say 2 milligrams twice a day. Then probably, yes, dose reduction would really help these patients to reduce the risk of hypoglycemia.
Thank you, Dr. Adlyne. That was a wonderful talk, and thank you so much for sharing your expertise. Now we'll move on to the next talk. And for this, I invite our moderator for the next session, Dr. Ranjanee, to introduce the topic and the speaker.
Thank you, Deepthi. After the scintillating talk, let us move on to the next topic of the day, which is, I think, outcomes of post-renal transplant IgA nephropathy, a single-center experience from Madras Medical College. To present this, we have our young, energetic consultant from Gleneagles, Healthcity, Chennai, Changanidi, who has done her DM nephrology from esteemed Madras Medical College from 2018 to 2021. Her general medicine was from Karnataka, from Manipal, and she has done her MBBS from PSG, Coimbatore. And obviously young, energetics, but still has got a lot of enthusiasm in interventions, critical care, and single-handedly also has done some multiple organ transplants and also effective management of other facets of nephrology. IgA is a very common disease. It's a most common glomerular disease throughout the world. And IgA in native kidney disease has not behaved the same way as it used to behave. It is the prognostic indication, the prognosis is not so good as it used to be in the past. Similarly, in post-transplant also, the recurrence actually normally in the past, it used to happen beyond 5 years or so. But now we have seen early recurrences also, and allograft dysfunction also happens. And a significant amount of people go to allograft failure. So let's see what the study from MMC has to tell us. So over to Dr. Changanidi.
Good evening. Thank you for the opportunity. Am I?
You're audible. Kindly share your screen.
shared, ma'am. Are my slides visible, ma'am?
Yes. Yes, please go ahead.
So my study is about the outcomes of post-transplant IgA nephropathy center. Slides.
Um,
I'm not able
Changanidi, can you be a little louder?
Ma'am,
Your slides are not
have I reached
moving.
my first slide?
Yeah, first slide is visible.
Can you
Okay.
stop sharing and reshare?
So,
So that-
as you all know,
Yes.
Yeah, now visible, Changanidi. Yeah, first slide is visible.
now,
You start moving.
okay. So, the commonest phenomenon approximately 20% of them reach end-stage kidney disease by 10 years, and 20 to 40% reach only not reach and stay as benign disease. Also, there is significant geographical variation in the distribution of this disease.
So we are not able.
For
Yeah.
instance, if the Asian For instance, the East Asian countries have a very high incidence of IgA nephropathy. Post-transplant, recurrent glomerulonephritis is the third leading cause of graft loss, next only to rejection and death. Coming to IgA nephropathy, recurrent IgA nephropathy, the incidence has been reported to as less as 13% to as high as 60%. The incidence is low in areas in studies where biopsy was done only when indicated. The incidence was very high when all biopsies were done. Initially, IgA nephropathy was to be very benign, and even if it recurs post-transplant, was thought to be inconspicuous. Now, studies have come and show that it is not so inconspicuous and have worse outcomes than thought. So we have very less Indian studies in that. So, quick pathogenesis of IgA nephropathy, multiple hits take place. In those with the genetic predisposition to develop the mucosal galactose deficient IgA nephropathy, there are various stimulants like infection, which leads to production of autoantibodies against this galactose deficient IgA1. Then there is formation of circulating immune complexes, which go get deposited in the mesenchyme of our kidney. Increasing complement activation. Apart from complement activation, various other mediators like endothelin-1 also have a role in progressive fibrosis and kidney damage. Briefly about the pathogenesis of IgA nephropathy. Aim of study was to analyze clinical characteristics, risk factors for recurrence, and post-transplant outcomes of kidney transplant recipients with IgA nephropathy either prior to transplant in their native kidneys or biopsy proven in their allografts. Ours was a retrospective study conducted at Madras Medical College. We assessed the outcomes of 66 kidney transplant recipients who had either IgA nephropathy in the native kidney biopsy or IgA nephropathy in the allograft biopsy. We studied the various risk factors for recurrence and outcomes from a period of 2003 to 2022. So our study population included total of 66 participants. The bigger circle shows you those with proved IgA nephropathy in their native kidneys. Overall, 57 people. And this smaller circle represents those who developed IgA nephropathy post-transplant, 20 people. The overlapping region shows those who had biopsy-proven IgA nephropathy prior to transplant and developed post-transplant also. The bright yellow part is those who had IgA nephropathy. Basic disease was not known. It could be possibly recurrent IgA nephropathy or de novo or donor derived. 9 of them were into this category. Coming to the results, we identified a total of 70 kidney transplant recipients over the 20 years. 4 could not be traced. Out of the remaining 66, 46 had IgA nephropathy prior to transplant but did not have recurrence. Remaining 11 proven to have IgA nephropathy in native kidneys had recurrence. 9 of them had post-transplant IgA nephropathy in whom the native kidney disease was not known. So, median time diagnosis for post-transplant IgA nephropathy 72 months with an interquartile range of 41 to 108 months. We had patients diagnosed as early as 15 days to as late as 12 years post-transplant. The incidence of recurrent IgA nephropathy and biopsy was done only when indicated was 19%. 19% if we take, if we consider those only with proven IgA nephropathy in the native kidney disease. But overall, the incidence, if we consider both with proven IgA nephropathy and in those whom we did not know the native kidney disease, the incidence comes to around 30%. By 5 years, 8 of them developed IgA nephropathy, and by 10 years, 17 of them had developed IgA nephropathy. So, mean creatinine at diagnosis was roughly around 2.5. And mean PCR at presentation was 3.1. These are the commonest indications for doing a biopsy in our study. Analyzing the risk for recurrence, age at presentation prior to transplant was 27 years. And median time to ESRD from the time of diagnosis of IgA nephropathy ending up in ESRD was 12 months. So both of them, when compared with kidney transplant recipients with no recurrence and those who developed IgA nephropathy, there was no significant difference as risk factors did not associate. So coming to gender variation, the entire cohort had 75% males and roughly 25% females. In those who had proven IgA nephropathy prior to transplant, the ratio was almost the same. In the entire cohort who developed IgA nephropathy post-transplant in their allograft, 90% of them were male and 10% were females. This the gender also did not associate significantly as risk factor. Coming to the type of transplant, in some studies, live donor kidney transplant, related kidney transplant was associated with significant risk factor. In our study, comparing DDR deceased donor and live donor, we didn't find a significant difference. We used 3 types of induction in our institution. This ATG, another one is with Netflix, and we use no induction also. Free induction, there's no significant risk factor. Studies have shown that regimen are protected against IgA nephropathy. Comparing those who were on tacrolimus and cyclosporine, and those developed post-transplant IgA nephropathy was not significant. The percentage was higher in audible, ma'am.
Yes, audible. Yeah. But slideshow.
Coming to outcome analysis, in post-transplant IgA, those who develop post-transplant IgA, they also have years 30%. 6 developed graft loss. Associated findings in those who had graft loss was prevention. 1 had HB positivity and 1 had collapse from prior to transplant. This confirms that not as high as 15%. Got who had IgA nephropathy prior to transplant and post-transplant, graft loss was 23%. Mortality was 16%. In those who had IgA nephropathy prior to transplant, various causes of graft loss were TME in three patients, rejection, one developed CMV with acute cellular rejection, one developed FSGS, and one had COVID and had graft loss. We also compared with one Indian study similar to our study done in SGPGA. They had developed our sample size was 66. We included both pre-transplant IgA nephropathy, post-transplant IgA nephropathy. They had included 51 patients. All were only post-transplant IgA nephropathy. Time to recurrence was median time to recurrence was 72 months in our study and 62 months in their study. Graft 30% in ours and 27% in theirs. Mortality was 15% in ours and 13% in theirs. We analyzed risk factors for recurrence and found no association. They analyzed the risk factors for graft loss and found mean creatinine at 5 years as a significant risk factor for graft loss. So, comparing with other studies worldwide about recurrence, trans data, as trans data registry, Australia, New Zealand registry, 5 years the recurrence is 5%, 10 years 10%, and 15 years 15%. The American study for post-transplant recurrent glomerulonephritis, the 10-year incidence was 19%, the 15-year incidence was 23%. The Mayo study conducted protocol biopsies. So their 1-year incidence was by itself as high as 12%, 3-year incidence was 42%, and 5-year incidence was 51%. So our study had 5-year incidence of 12% and 10-year incidence of 25%. When in certain studies, our protocol biopsy was less. Time zero allograft biopsy itself showed IgA deposition in the kidneys in 16% of patients. So, known risk factors for recurrence can be classified into 3. One is recipient-related risk factors. Prior to that, high serum IgA levels are higher risk of recurrence, younger age of transplantation, and rapid progression to IgA end-stage kidney disease, and higher degree of proteinuria. Of these, has been always significantly and persistently associated as risk factor. Various studies. Donor-related risk factors. Living donor kidney transplant and certain HLA types have been associated. Transplant-associated risk factors. Shorter duration of steroid use was found to be a risk factor for recurrence. Increasing time after transplant. But from this, ATG use was found to be protective against recurrence. So, coming to the treatment, we have various treatment modalities which can be classified as immune suppressive modalities and nephroprotective modalities. Conventional treatment is to give protection against proteinuria, nephroprotection, using RAS inhibition and systemic steroids. But now it is changing. We have the budesonide after the NephIgArd study, and various complement inhibitors are also being studied, like avacopan, iptacopan, and BAFF/APRIL inhibitors are also studied. For nephroprotection, the endothelin receptor antagonists and the non-steroidal mineralocorticoid receptor antagonists are also studied. Conclusion. From our study, we concluded that this subset of patients, those with IgA nephropathy undergoing kidney transplant, as well as those who developed IgA nephropathy in the graft, had high rate of graft loss and mortality. No significant risk factors were associated with IgA nephropathy recurrence. Limitations of our study. Actual incidence of recurrent IgA nephropathy could not be calculated. As we did not biopsy all the patients with IgA nephropathy, we did not follow a protocol biopsy. Also, we took all those with post-transplant IgA nephropathy, recurrent IgA nephropathy. This could have been de novo or donor-derived also. And we analyzed the risk factors. The study also did not analyze the genetic risk factors and treatment options or outcomes for recurrence. because for most of the patients with recurrence, we had used only RAS inhibition. We had not aggressively treated with any immunosuppressive modalities. So future in IgA recurrence, when planning for transplantation, we can modify the proven modifiable risk factors like not tapering the steroids early, using ATG injection, and avoiding living donor kidney transplant. Instead of going for biopsy, we can maybe use biomarkers to assess recurrence. For example, IgA levels at that time at baseline, and then monitor every year or like that. And the recent years, pathological markers of severity have also been identified. Previously, IgA nephropathy complement activation was thought only to be mediated by alternate and lectin pathway. Now, it is increasingly recognized as C1q deposition. The classical pathway occurs commonly in recurrent IgA nephropathy. When C1q deposition occurs in either native or post-transplant IgA nephropathy, it has a very detrimental prognosis. Our evolution in the understanding the pathogenesis apart from complements, other factors like endothelin 1 and various B cell factors like BAP, BCL, and spleen tyrosine kinase inhibitors are also being studied. Evolving treatment options. Some Asian countries have also done tonsillectomy 1 year post transplant and found to be effective. So budesonide is also evolving, and we can use it as a treatment option in IgA in recurrence. Like other glomerulonephritis like lupus, we need a proposed treatment for IgA nephropathy also, which we do not have. Then we can have a better future in IgA nephropathy recurrence. Thank you.
Congratulate Changanidi for that beautiful presentation. It was quite crisp, and I think it was mainly observation study, but I think it was it had definitely given all the important inputs, and I think it reiterates actually, and it's in parallel with studies done at various other centers. So we have good 30% graft loss actually, and also a good 5 years recurrence rate of around 12%. But only thing Mayo study had shown more recurrence rates of around 51%.
Protocol biopsy.
Yeah, okay, yes. But I think in actual also, if we start doing protocol biopsy, probably our rates also would be, I think, go up. And also, I think wanted to reiterate that mesangial C1q deposits are not so common in native disease as it's common in IgA post-transplant. So that is one important point actually, which is I think brought out. But have you done, is it available to do C1q deposits possible in our countries? Is it possible?
No.
Mesangial
in our
deposits can be checked?
I have.
Okay.
No, I'm not sure.
Ranjanee, we are doing C1q for IgA nephropathy.
IgA nephropathy post-transplant.
We have started doing, we've got a paper also, which we are publishing.
Okay.
Once it's ready, I'll share it with you.
Okay, ma'am. Okay.
And actually, I wanted to know what about this MEST classification? When there was a recurrence, was it same as the pre-transplant biopsy? You said recurrence, isn't it? Recurrence
Yes,
of IgA. Yeah.
No, ma'am. That pre-transplant biopsies could not be traced, ma'am. Only post-transplant biopsies we traced. In that T2, in those who had graft loss, T2 was found in 4 of them, and T was found in 2 of them, ma'am, out of the 6 graft loss.
Okay. So you did not see the correlation.
No, ma'am. Pre-transplant and post-transplant.
Yes, MEST, whether it was the same as the pre-transplant, the biopsy.
No.
Okay.
Was donor-specific antibodies both de novo or preformed increase the risk of IgA recurrence?
Not having donor-specific antibodies, ma'am. In one study, it has proven to be a risk factor, ma'am.
Okay, but in your studies,
having high levels of we do not do donor-specific antibodies.
Okay. Okay.
DSA is not done.
Okay.
And about the serum IgA levels, you said those who had high levels recurred.
No, ma'am. It is a risk
Post-transplant, did you
factor.
check
It is a
this?
risk factor, proven risk factor, ma'am. We did not measure the levels, ma'am. Maybe
Okay,
in
post-transplant. You didn't measure. Okay. Oh,
no, ma'am.
okay. Right.
I think we have a question in chat box.
Dr. Deepthi, there are some questions. No?
Yes, ma'am. There's one question. Is there any role of plasmapheresis in recurrent IgA in graft kidney?
So far, even in native kidneys, plasmapheresis has not been tried in IgA. We have this other treatment options like proteinuria management and steroids. Even rituximab was not found to be helpful because and only bortezomib was helpful because plasma cells are the main targets for us. I'm not really sure whether it has been tried about plasmapheresis.
Probably if you have IgA vasculitis, there's a possibility that it can be used.
Then to remove the
But now we have rituximab, which is almost equivalent to plasma exchange in other diseases also like ANCA vasculitis. So I think rituximab, I don't know, but IgA
is helpful in
of any. So probably in vasculitis, probably plasma exchange can be tried.
Yes, ma'am. I think there are no further questions. Thank you, Dr. Changanidi, and thank you, Ranjanee ma'am, for moderating this session. And it was a
Thank you.
nice presentation. As a pediatrician, the one thing that caught me was you said in limitations that you couldn't assess the genetic risk factors. So, were there any specific genes that you would have wanted to look at, or
IgA nephropathy genes targeting MHC.
yeah, gene panel, like you said, you acknowledged it as a limitation, but are there any genes which we can look at in such cases which can predict the recurrence?
There are various genes, ma'am, mainly targeting MHC.
Okay.
Related.
Do you have any long-term follow-up study on glutamate?
Budesonide, ma'am.
Long-term follow-up use of that. The improvement regarding proteinuria, hypertension, progression, etc. Is it really good in arresting progression? Any
In
ideas?
our institution.
No, I'm not asking about your experience or institute. In the literature, it's available.
Budesonide, ma'am.
Yeah. Long-term use and long-term follow-up.
9 months they have used and was found to be helpful, ma'am. Long-term follow-up.
No, in 9 months use, how much it they arrested? Comparative study?
Not much.
I think that will be interesting to know that because now every one of us are using that. And it's available freely. So I just wanted to know what is the long-term outcome of it. Any literature review you have? Thank you. Nice study you have done.
Thank you.
Thank you, everyone. Jayalakshmi ma'am, I would request you to give the closing remarks for today's session. Indhumathi ma'am?
Dr. Jayalakshmi, you
Yeah. I'm unmuted.
Yeah.
It is a very good session and a nice way to begin a new academic year. Diabetes is something which we always keep seeing, and Dr. Adlyne's discussion was very good, very practically very useful, and with a lot of insights about the new molecules. Thank you, Dr. Adlyne. And the next topic on IgA nephropathy is actually something again that we see very regularly. And we do have a lot of cases which progress very fast, and I mean, I by mistake I told C1Q. We have actually done C4D staining, and we are going to have a paper on that. C4D. Hello.
C4D.
C4D in IgA nephropathy.
Not C1Q. Not
Not
C1Q.
C1Q. C1Q, we want to look at the existing reports and see whether there is any C1Q positivity there, which we are yet to start. But the C4D, we have already got, a paper which we presented in the last southern chapter, where we found there is an association of C4D and the rapidity in the progression of IgA nephropathy. So that is being published. So IgA nephropathy is actually a very hot topic with the newer drugs also coming around, and we should have a classification and a treatment protocol like how we have for SLE, which I think we all should be getting it shortly, with a lot of studies going on in IgA nephropathy. Thank you for both the topics. Thank you, presenters and the chairpersons. Thanks to Muthu Madam and Prabha Madam for gracing the occasion. Thank you all for attending in good numbers. Thank you, Indhumathi.
Thank you. Thank you.
Thank you all.
Thank you all.
Thank you so
Thank
much.
you all.
Yeah.
Thank you, madam.
Thank you.